Hi, thank you so much. I'm absolutely honored to be here speaking. It's a passion of mine to take care of patients with ovarian cancer and at risk for, and certainly a passion of mine to speak about it. So let me get my slides up. Can everyone see my slides? I'm going to assume silence is yes. So
Yes, we
again,
can see them, Dr. Long. Go
great.
for it.
Kara Long. I am a ovarian cancer surgeon at Memorial Sloan Kettering Cancer Center. I have no disclosures other than I have received research funding from these organizations. Just a little bit about ovarian cancer in 2024. I'm kicking off the program today, so I wanted to start with some basic facts. Unfortunately, there will be about 20,000 new cases of ovarian cancer diagnosed in 2024 in the United States. And ovarian cancer remains one of the top 10 causes, the sixth leading cause of cancer deaths among women in this country. So we still have lots of work to do. Just a little bit about risk of the disease. The risk of developing ovarian cancer in the general population, meaning an average person with no identifiable risk factors, is about 1.5% over a lifetime. Patients with high-risk family histories or high-risk genetic mutations can have much higher risk than that, up to about 40% over a lifetime. Where the challenges really come is that there are rarely symptoms of this disease when it is in its early forms. And despite lots of work, years of work, and millions of dollars spent, we still do not have a screening test for this disease. And so, unfortunately, when patients come into the doctor, they already have advanced stage at the time of their diagnosis. And what I'm going to talk about today is surgery. And surgery remains a mainstay of both prevention and treatment. Now, I mentioned that there are rarely symptoms of early disease, but in our group effort to spread awareness about the symptoms of advanced disease, I'm going to talk about one of them, B, and that's for bloating. So patients who have bloating or abdominal swelling should be evaluated, as this is a symptom of ovarian cancer and is unfortunately a symptom of advanced disease in many patients. So just remember this as we all continue our presentations. So I'm going to start off talking about prevention. In a perfect world, no one would get this disease. We would be able to prevent it from ever starting in patients. One of the most important aspects of preventing ovarian cancer is identifying who is at risk for this disease. We know that about 20% of ovarian cancer is related to a genetic mutation carried in the bloodstream, inherited from parent to child. This is a huge amount of patients who we can identify as high risk based on family history, get them to genetic testing, and then make prevention plans. These mutations are mutations like the BRCA1 and BRCA2 mutation, but there are many more that have been discovered in the past decade, like the RAD51C, RAD51D, BRIP1, and more mutations that patients can have, and we know how to prevent in these situations. If we identified every woman with a predisposing mutation to ovarian cancer, we could prevent over 4,000 of the annual 20,000 cases diagnosed in the United States. So in patients with a family history or in friends that you may know who have a family history of this disease, encourage them to get genetic testing. We know that ovarian cancer is not actually just one disease. There are many different subtypes. The most common subtype, and the one that is going to be really kind of the focus of some of our talks today and is going to be a focus of my talk, is high-grade serous carcinoma. High-grade serous carcinoma accounts for a little bit more than 3/4 of all ovarian cancer diagnoses. And it is the one that is associated with the most common genetic mutations like BRCA1 and 2. But it isn't the only kind, and there are others like clear cell, endometrioid, mucinous, and low-grade serous carcinoma, which my friend Dr. Gershenson is going to be speaking about. In talking about high-grade serous carcinoma, which again is the most common type, it's important to discuss this discovery that's been made in about the past 20, 25 years. About 25 years ago, someone was studying the fallopian tubes of patients who had undergone preventative surgery, and they found these teeny tiny lesions, microscopic lesions in the fallopian tube that after much studying were determined to really be the precancer lesion to high-grade serous carcinoma. They're called stick lesions or serous tubal intraepithelial carcinomas. And what we know now over the past 20 years is that the majority of high-grade serous carcinoma, maybe even all high-grade serous carcinoma, probably originates in the ends of the fallopian tube. This explained to us a lot of the challenges that we had had in early detection and finding early symptoms. Since the fallopian tube is open and exposed to the abdomen, these little cells would just scatter about, and patients would have disease that had spread before they even had a symptom, certainly before anything could be seen on an ultrasound or in a blood test. And it's the only surgical picture I have in the talk, but this picture on the right side of the screen, you can see a normal looking ovary on the left, and on the right is a tumor coming out of the end of the fallopian tube. So this important discovery led to some really changes in how we think about prevention. So the term salpingectomy refers to removal of fallopian tubes and sparing or saving of the ovaries. And as we've learned more about the fallopian tube origin of high-grade serous carcinoma, we've asked the question, well, can we just remove the fallopian tubes to prevent this disease? For years, we've been recommending to high-risk patients removal of the tubes and ovaries as their preventative step. However, removal of the ovaries results in infertility and premature menopause. If we could just remove the fallopian tubes, could we possibly prevent this disease while preserving ovarian function? And there is a lot of data from large population-based studies and databases that says that removing fallopian tubes might be effective. So this procedure called salpingectomy, and another term for it is early salpingectomy, delayed oophorectomy, is being studied right now in the United States and abroad as an interval step for high-risk patients. So patients who want a preventative step earlier than is recommended, they have their ovaries out, or patients who aren't willing to have their ovaries out can have their fallopian tubes out and come back at a later date for ovary removal. And the two trials that are open in the United States right now looking at this are the WISP trial and the SORAC trial. One important thing is patients always ask me, well, when is this data going to be ready? When can I know that removal of the fallopian tubes is enough to prevent? And I say, well, it's going to take a long time because we have to do it in all these patients in a safe way, and then we have to wait and hopefully watch these patients get very old and stay very healthy. So the next question is, what about in average risk patients? I mentioned that 20% of high-grade serous carcinoma or 20% of ovarian cancer is related to a genetic mutation, but what about the other 80%? Well, we know that many patients who develop ovarian cancer didn't have any risk factors, again, up to 80% of them. So how might we utilize this knowledge to help prevent in those patients? So the concept of opportunistic salpingectomy has been raised. What opportunistic salpingectomy is its removal of the fallopian tubes in an average risk person who's undergoing another abdominal or pelvic operation. So someone who's already going to the operating room, who has completed childbearing, and could have this opportunity for a preventative operation. Well, we know that removal of the fallopian tubes might offer some prevention. And in these large population-based studies, it says that maybe removal of the fallopian tubes in average risk patients could reduce their risk of ovarian cancer by up to 65%. And more data is coming about this. The Canadians are a couple steps ahead of us. They have been removing fallopian tubes at the time of hysterectomy and instead of tying tubes or instead of tubal ligation for some years now. They started back in the early 2000s. And they recently published their data in 2022, looking at this population of women average risk women, who had their fallopian tubes removed during another indicated operation. And using some predictive models, they estimated that about 25 of those women should statistically have been diagnosed with high-grade serous carcinoma. But in the group that had their fallopian tubes removed, there were 0 cases. So there is some exciting data that this option of fallopian tube removal at the time of another surgery might, in fact, be very beneficial for preventing this disease in the general population. And scientists and colleagues have looked at this from kind of a modeling perspective, meaning they've taken data and they've done predictions. They've tried to see, is this cost effective? Might this help in the general population? So if we removed patients' fallopian tubes at the time of hysterectomy, meaning at the time that the uterus was being removed, even when the ovaries were staying behind, and we removed fallopian tubes instead of tubal ligation or instead of tube tying in patients who wanted permanent sterilization, we could prevent about 1,854 deaths per year in the United States from ovarian cancer and save almost $445 million healthcare dollars. So this could be a huge opportunity to save lives, save suffering, and money in our country. So opportunistic salpingectomy. Well, all of the experts agree right now that fallopian tubes should be removed at the time of a hysterectomy or at the time of a patient undergoing a surgical sterilization procedure. But a big question is asked, are there other opportunities? Could we make these numbers even more impactful? What about patients who have completed childbearing, of course, who are undergoing surgeries like gallbladder removal or colon surgery, hernia repair, appendectomy? So colleagues of mine and myself are currently studying this. Can we expand these options for patients that might want to prevent this terrible disease? So moving on from prevention to early detection. So if we can't prevent the disease, can we find it early? Well, one of the challenges with this is how early do we actually need to identify these lesions or these precancers in order to make a difference? This was a very important study published in 2022 that looked at the risk of developing high-grade serous ovarian cancer in patients who were found to have a precancer lesion in their fallopian tube. And this microscope image on the left is what that looks like, a stick lesion or a precancer to high-grade serous carcinoma. It's teeny tiny. You can only see it under the microscope. And unfortunately, what we found is that in patients who had a stick lesion at the time of their ovary fallopian tube removal, were found to have a risk of about 27.5% of developing high-grade serous carcinoma in the lining of their abdomen in the 10 years following that operation. This is compared to less than 1% in patients who did not have a stick lesion found. What this tells us is that in order to truly prevent high-grade serous carcinoma of the ovary, we truly need to find these precancers when they are at the tiniest stage. If they are not that tiny, we might not actually be helping patients. Some work that my colleagues and I are doing at Sloan Kettering is looking at little tiny nanotubule microsensors and machine learning. And if we can take these little tiny microsensors and expose them to fluid, either from the patient's bloodstream, from the patient's abdomen, or maybe even from vaginal secretions or cervical secretions, can we use emitted light frequency to teach a computer which patients have ovarian cancer or which patients have a precancer? So we're trying to use novel technology and computer, basically artificial intelligence, to see if we can develop better screening tests. Similarly, colleagues of mine at MIT are trying to understand better ways to evaluate fallopian tubes that are removed during surgery. It's very tedious to find these little microscopic precancers in fallopian tubes. And if we can have a faster, better tool to look at fallopian tubes and image them, could we possibly find these precancers early? Maybe we could even develop imaging that could look at fallopian tubes before they're removed from patients. So unfortunately, these technologies are pretty far from being available in the clinic, but there are some brilliant people working on them. Moving on to surgical advancements in the treatment of ovarian cancer or the treatment of advanced disease. Well, we know, and my colleagues and I at Sloan Kettering are very passionate about this, that debulking surgery or removing all visible, seeable, and touchable cancer remains the most important modifiable prognostic factor for patients. Meaning, of all the things we can't change, The one thing we can change is thorough and good, safe surgery. So, as you might know, there are several different windows for surgery in the treatment of ovarian cancer. Primary debulking, or debulking surgery right at the time of initial diagnosis, with the goal of removing all disease. Then you can have what's called interval debulking surgery, or surgery after neoadjuvant chemotherapy is delivered. And there are some advancements in terms of techniques that can be done at that time, like heated intraperitoneal chemotherapy. And then, of course, there's surgery for advanced disease, which I think is going to be covered in some of the later talks. So one area where we've really kind of pushed the limits of surgery for advanced disease is traditionally it's thought that patients with stage 4 disease or disease outside the abdominal compartment weren't candidates for surgery, but we've realized that we can really push the envelope with this. Just because us as gynecologists aren't necessarily trained to operate outside the abdomen and the chest, that doesn't mean that we can't use our colleagues to help us learn how to do that, and use our colleagues to help us in the operating room to really push the limits, push the envelopes of what kind of disease is considered resectable. So my colleagues at Sloan Kettering and others around the world have published that removal of stage 4 disease in the chest, as it pertains to lymph nodes or spots in the lining of the chest, can allow for complete resection, surgical resection of cancer in patients that previously were deemed unresectable. And we at Sloan Kettering have published our experience on this, showing that this is safe and feasible and really can increase the number of patients who are candidates for surgery. This is a hot topic and one that I get asked about a lot, but what about minimally invasive surgery for ovarian cancer? Well, we know that minimally invasive surgery, laparoscopy or robotics, so surgery through tiny incisions, can be performed for the management of suspicious ovarian or adnexal masses. That's something that everybody agrees upon. We know that minimally invasive surgery can be done as a staging procedure, meaning biopsying lymph nodes and other tissues around the abdomen to see whether cancer has spread there. But what about debulking surgery? Can minimally invasive surgery be expanded to debulking surgery, or what I described previously as removal of visible, touchable lesions? And I will say that this remains a controversial topic. So, is there a role? This is something that's currently being studied. So right now, minimally invasive surgery, as it pertains to debulking, has been suggested as a tool after neoadjuvant chemotherapy, meaning patients get chemo and then they're considered for surgery. And again, it's been suggested that minimally invasive surgery might be appropriate in those patients if they have had a good response to chemo, meaning the CA-125 has normalized, that there is minimal disease on their CT scan, or very few sites of disease. And in this situation, it's very important that the surgeon be an experienced high-volume surgeon, because minimally invasive surgery, it is harder to explore every surface of the abdomen. And so in this situation, it is recommended that be kind of reserved for select cases. Like I said, this is controversial. We're not actually offering minimally invasive surgery for ovarian cancer debulking at Sloan Kettering because I think some of us feel like maybe we're not ready for it. We are concerned that maybe complete resection is something that is being compromised in taking our big incision to small incisions. However, there is a very important prospective trial underway right now called the LANCE trial, which is evaluating whether minimally invasive surgery can be used. Another, no pun intended, hot topic in surgery for ovarian cancer is HIPEC, or heated intraperitoneal chemotherapy. And what HIPEC is it's a heated, very hot chemotherapy that is delivered directly into the abdominal compartment during a debulking surgery. We know that heat can increase the penetration of the chemotherapy into tissues. We know that heat can also increase the sensitivity of cancer cells to that kind of treatment by impairing the DNA repair, right? Chemotherapy damages DNA, and hot chemotherapy can prevent that DNA from then trying to repair itself. And we know that heat can induce cell death, activate heat shock proteins, inhibit the formation of new blood blood vessels and can actually have a direct cytotoxic or a killing effect on cancer cells by denaturing or ruining proteins. There is a very important study that was published looking at HIPEC, or heated intraperitoneal chemotherapy, at the time of interval debulking. Again, after neoadjuvant chemotherapy, patients were basically randomly allocated to have a debulking surgery and then either get HIPEC or not get HIPEC. And what they showed, that is in these patients who also had an aggressive surgery, that HIPEC actually prolonged their remission or prolonged their recurrence-free survival, as well as their overall survival. And we found that there was not significantly increased risk with using HIPEC. So right now, HIPEC is considered a standard acceptable therapy at the time of interval debulking. The question has been raised as to, well, what about HIPEC at other times, at the time of primary debulking? Well, the results are mixed so far, and there is a very important trial called the OV-HIPEC-2 trial, which is currently underway trying to answer this question. We want to give patients the best therapies that have been proven, and so we have to prove them at these different time points. The results won't always be the same. So finally, one advancement in surgery, or something that we're trying to advance in surgery that is near and dear to my heart, has to do with the impact of stress at the time of surgery for ovarian cancer. We know that stress, both physical stress on the body, like pain, but also on the mind, like anxiety or psychosocial stress, are not good for the immune system, and they actually create an environment that cancer thrives in. So stress, again, physical or emotional, is not good for patients with cancer or at risk for cancer. And so the question has been asked, how can we take care of patients during this extremely stressful time, perform very physically and emotionally stressful operations on them, and help to manage that stress so that we don't create a simultaneous problem? Well, we know that stress reduction in many different forms has proven benefits. We've seen this in many different solid tumors, not just GYN cancers. And in fact, much of the research comes out of breast cancer and colon cancer. We know that stress-reducing medications like beta blockers and COX-2 inhibitors have been shown to decrease the stress reaction in patients, which creates a more favorable microenvironment for the immune system and therefore a less favorable environment for cancer. We also know that various anesthesia techniques used at the time of cancer surgery can have the same effect. This graph on the right shows the impact on our patients with ovarian cancer of having an epidural, which is a type of anesthesia, along with general anesthesia at the time of their initial ovarian cancer surgery. And what this graph shows, and it blew us all away, is that when we use epidurals in our patients who are getting their initial upfront surgery, that at least in a retrospective cohort, those patients had longer survival. They actually lived longer with their cancer after controlling for all different factors when they had an epidural. And it's been postulated that this epidural, again, reduced the stress response, created a more favorable environment for the immune system, a less favorable environment for the cancer. And then similarly, patient-centered techniques like mind-body resilience training and music therapy, there are all individual studies showing that these various stress reduction techniques have benefits. So at Sloan Kettering right now, we have a trial open called the PRESERVE trial, where patients who are undergoing surgery for advanced ovarian cancer receive a bundle of interventions: COX-2 inhibitors, beta blockers, total IV plus epidural anesthesia, as well as music therapy and mind-body resilience training. And right now, we're really seeing whether this bundle of interventions is feasible to patients, whether patients have a good experience with it. And then we are studying the effects in the patient's blood and on the patient's tumor to see whether these impacts had an effect on the microenvironment, which might result in long-term survivals. So very exciting things going on from all different levels as it pertains to surgery in ovarian cancer. So that's really all I wanted to talk about today. It was kind of a whirlwind review of prevention and early detection and treatment. I just wanted to thank everyone for having me here today, and thank you for everyone for listening to me talk.